So good morning. Today's session is on MRI clues to differentiate between MS, NMOSD and MOGAD. And I'm Dr. Surabhi and I'll be presenting this, and the session will be chaired by uh, Kesavadas sir and Sruthi madam. So for an introduction, distinguishing MS from other relapsing inflammatory autoimmune diseases of the CNS, such as other primary demyelinating disorders like NMOSD and MOGAD, is crucial in clinical practice because the prognosis as well as the therapeutic strategies are different for different diseases. And so MRI plays a crucial role in the ultimate diagnosis, confirming and to exclude other medical conditions, and also to for the evaluation of asymptomatic or symptomatic inflammatory lesions during follow-up. So now we'll see first multiple sclerosis. So according to the acronyms consensus recommendation, this is a standardized MS MRI protocol which they have recommended. For brain, at least 1.5 Tesla should be there, and for brain, the core sequences will be 3D T2 flare, axial T2 weighted images, and T2 susceptibility images like SWI or GRE, and also that is mainly to visualize the cortical vein sign, and also the post-gadolinium based contrast T1 images. And for the spinal cord, the sagittal as well as the axial T2 weighted as well as the post-contrast T1 images. And for the optic nerve, it is a orbital cuts, the coronal fat suppressed T2 weighted or stir images, and also the gadolinium based fat suppressed T1 coronal cuts. So in our center, basically the axial T1, T2, as well as the sagittal T2, as well as 3D flare images. Along with that, the SWI and the diffusion weighted sequences, as well as the post-contrast T1 sequences are used. So in multiple sclerosis, the lesions are usually asymmetric and they affect the white matter of the cerebral hemisphere as well as the brainstem, cerebellum, and they involve the cortex as well as the deep gray matter. And the typical lesions are small. They are sharply demarcated, usually less than 1 centimeter lesions, although larger lesions can also occur. And if there is a lesion, the lesion should be at least 3 millimeter uh, to count. And also based on locations, but size can vary. That is, if it is in the brain stem or in the corpus callosum, the lesions will be less than 3 millimeter. And lesions smaller than 3 millimeter, especially if it is in the deep white matter and in the basal frontal areas, we cannot count that because it can be due to other small vessel ischemic changes as well. And the typical lesions are the Dawson's finger lesion, that is the perivenular lesions, which are ovoid or round in shape, and they are perpendicular to the axis of the lateral ventricles. So this is an axial flare image which is showing the Dawson finger lesions. That is, they are mainly sharply demarcated small ovoid lesions which are perpendicular to the axis of the lateral ventricles, and they will be in touch with the lateral ventricle. And so this is a sagittal session showing the Dawson fingers. And the periventricular lesions, they should be in direct contact with the lateral ventricle. And in MS, the typical lesions will be in the inferior temporal lobe, which is not found in other demyelinating disease like NMOSD. And there should not be any intervening white matter between the lesion and the lateral ventricle. And the periventricular lesions include corpus callosal lesions also, which abut the ventricles. And however, lesions which are abutting the lateral ventricle found in the deep gray matter are not considered periventricular. So here we can see in the inferior temporal lobe, small ovoid lesion which is abutting the lateral ventricle, which is typical for MS. And only lateral ventricle is considered for periventricular lesions. And for juxtacortical and cortical lesions, So juxtacortical lesions are a hallmark feature of multiple sclerosis, especially to differentiate from NMOSD. These kind of lesions are not seen in NMOSD. However, cortical lesions can be seen in MOGAD. So this juxtacortical lesion, they will affect this U fiber and they will extend towards the cortex. And so these type of, in ischemia also, mainly subcortical lesions are there. That is, and white matter will be between the lesion and the cortex in small vessel disease. And this cortical lesions that do not involve the juxtacortical white matter, they are difficult to see in FLAIR images. So three other 3D sequences can be used to visualize this intracortical lesions. That is DIR, PSIR, or MP-RAJ sequence can be used. But this does not come under the MS protocol, MS MRI protocol. But DIR sequences are used if we want to see the cortical lesion in our center. So these are the cortical lesions. They can be curvilinear or worm-shaped lesions, or oval lesions, or wedge-shaped lesions. And this is a special sequence used to visualize, in which the CSF is very much suppressed to visualize this cortical lesion. Here also we can see small ovoid lesions in the cortex. So coming to the infratendoral lesion, they mainly involve the brainstem, cerebellar peduncles, and cerebellum, and they preferentially affect the floor of the fourth ventricle. And also in the pons, we can look for these lesions in the surface of the pons. That is mainly at the trigeminal root, entry zone, as well as in the intrapontine lesions will be seen in MS. And also in the middle and the superior cerebellar peduncle, the periaqueductal gray matter, cerebellar white matter and cortex, and medullary pyramids. So in this image, we can see in the floor of the fourth ventricle, small, almost like a sharply demarcated lesion can be seen. Here also in the surface of the pons, at the root entry zone of the trigeminal nerve, the floor of the fourth ventricle, and also one typical site is in the medulla, the medullary pyramid. Pyramids are more involved in multiple sclerosis. And also in the pons, it will involve the middle as well as the superior cerebellar peduncle. And here we can see in MS, it will be more well-defined, sharply demarcated lesion compared to other demyelinating disease like MOGAD and NMOSD, in which this middle cerebellar peduncle can be involved in all the three diseases. And the lesions can also be seen in the cerebellum. So here we can see inside the pons intrapontine lesions, well demarcated intrapontine lesions can be seen, which is seen in MS. Coming to deep white matter lesions, they are common in multiple sclerosis. However, deep white matter lesions are seen in other diseases, small vessel ischemic disease. So it has got a low specificity. That is why it does not come under the diagnostic criteria for dissemination in space in MS. And however, such lesions can contribute to the diagnosis for dissemination in time. That is, in follow-up, if these deep white matter lesions, new lesions are coming, and if they're harboring a cortical vein sign or a paramagnetic rim, then that it can be included in dissemination in time. A central vein sign or paramagnetic repletion, then this deep white matter can be included in dissemination in time. Then contrast enhancement. So this gadolinium-based contrast enhancement is a transient feature in multiple sclerosis. That is with a median duration of less than 4 weeks. However, slow enhancing lesions can also be there, like which can have more than 2 months of enhancement in multiple sclerosis. And so they rarely persist beyond 2 to 3 months. And lesions with enhancement for longer than 3 months, we should consider other alternative diagnosis like tumor, lymphoma, or vascular malformations. And this enhancing lesions, they usually have a nodular pattern, a ring-like pattern, or an open ring pattern. So in this image, we can see the nodular enhancement. And here we can see a ring-like ring pattern of enhancement. And here we can see the open ring enhancement. And the ring will be open towards the gray matter. And because the active part of the demyelination, where there is blood-brain barrier dysfunction, is seen towards the white matter. And sometimes the lesions can be tumefactive lesions, that is more than 2.5 centimeter. with subtle mass effect and can be seen. So this is not a tumefactive multiple sclerosis, but if there is a solitary tumefactive lesion, it is difficult to differentiate if it is MS or NMOSD or MOGAD, because it can be seen mostly with MOGAD followed by NMOSD followed by multiple sclerosis. So sometimes biopsy might be required in these kind of lesions, and it can show a ring type of enhancement. And coming to central vein sign, so this identifies the perivenous distribution of multiple sclerosis lesion. That is, the demyelination is occurring around a vein. So that is why it is not a central vein sign. So this is, to pick up this, we need susceptibility weighted MRI sequences. That is mainly SWI. But with 1.5 Tesla, it is somewhat difficult to identify this sign. So it can be seen in SWI or face images to pick up the sign. And so we have to look for a hypoindence dot or a hypoindence line, which is in the center of the lesion. And so it runs partly or entirely through the lesion, and it is positioned centrally in the lesion, regardless of the lesion's shape. And there are some exclusion criteria. That is, if the lesion is less than 3 millimeter, we should not check for the sign. And if the lesion is merging with another lesion, that is in confluent lesions, we cannot see for the sign. And also, if there are multiple distinct veins, it should be excluded. And if the lesion is poorly visible, then it should be excluded. So if this is a susceptibility weighted T2 image in which we can see the central, it is seen as a hypoindence dot inside the in the center of the lesion. So this is the same lesion in the sagittal view, which is seen as a small hypoindence line in the center. And in the routine flare sequence, as we can see, it is a lesion is hyperindence, but the sign is not seen. And this is a susceptibility SWA image in which we can see the hypoindence line running centrally through the lesion. Coming to the select 6 method. So if there are multiple lesions, then if the central vein sign is positive in at least 6 lesions, it is considered as significant. And if it is less than 10, only less than 10, 10 or less than 10 lesions are there, then majority of the lesions should be having the central vein sign to take it, to consider it as significant. So if using the select 6 rule, there is a good sensitivity and excellent specificity for multiple sclerosis. And in radiologically isolated syndrome also, 95% of the patients studied fulfill the select 6 rule. And so this central vein sign, it is relevant because for previously, to diagnose MS, we needed dissemination in space and dissemination in time. So according to the 2024 McDonald's criteria, if dissemination in space is there, that is 2 lesions in at least 2 anatomical regions is there, then instead of the dissemination in time, if cortical central vein sign is there, then we can diagnose MS. And also in RIS also, if dissemination in space is there, then if central vein sign is there, then we can diagnose it as MS. And also, if there is a single lesion in a single anatomical location with central vein sign, if CSF positivity or dissemination in time is there, we can diagnose it as MS. So that is the relevance of central vein sign. Coming to paramagnetic rim lesions. So this is actually in a chronic active white matter lesion, which is seen in multiple sclerosis. The periphery of the lesion will have some iron-containing microglia. So this is picked up as a paramagnetic rim lesion in susceptibility weighted sequence. So if so that means a chronic active inflammation is going on, and so it portend a poor prognosis for the patient. And but this lesion, if it is there, it is highly specific to multiple sclerosis. And so so when the after the lesion inception, this paramagnetic rim will occur after 1 month, and once established, it can have an estimated half-life of about 7 to 10 years. And so it is detected using susceptibility sensitive images. And so it is a discrete rim with paramagnetic property that is continuous in at least 2/3 of the outer edge of the lesion. And how do we identify this lesion? This lesion should be T2 hyperindents, and it should be in large lesions, the core of the lesion will be T1 hypoindents, and it is a chronic lesion. So it should not enhance on post-gadolinium contrast. So that is T2 hyperindents, core of the lesion being T1 hypoindents, and it should not enhance. So in these lesions in susceptibility weighted images, we can see the paramagnetic rim. So in this phase, this is a phase sequence in which we can see here one lesion and it has got a rim around it, hypoindent. So that is a paramagnetic rim lesion. And so this is the corresponding T2 sequence in which it is hyperindents. And this is a post-contrast T1 sequence in which the core is actually hypoindents and it is not enhancing. So this is a paramagnetic rim lesion. Here also we can see a periventricular lesion with paramagnetic rim. Here also in SW image, we can see the periventricular lesion having a paramagnetic rim. Coming to optic nerve lesion in MS, so mostly MS will have unilateral optic neuritis in 95%. Bilateral can be seen in 5%. And so the lesion will be short. It will be less than 50% of the length of the nerve. And usually it will be seen in the intraorbital and the intracanalicular optic nerve. And in the acute phase, in less than 3 weeks, some optic nerve swelling can be seen at the lesion site. And however, this optic disc swelling, perineuritis, optic chiasmal involvement is rare in MS. And it can be optic nerve involvement. We can take the orbital cuts, that is fat suppressed T2 weighted sequences and post-gadolinium contrast T1 to look for enhancement of the optic nerve. So here we can see this is a fat suppressed T2 weighted sequence in which the left optic nerve is hyperindents and the right is not. So this is left optic neuritis, and in the post contrast T1 sequence, we can see the enhancement in the left optic nerve. And here we can see it is less than 50% of the nerve, and it is seen in the intracanalicular and the intraorbital part of the optic nerve. And coming to spinal lesions, it can occur at any level, but it is cervical spine is the most common location, 50 to 60%, followed by upper thoracic region in 20 to 45%. And it can have associated localized spinal cord volume loss. And in acute inflammatory lesion, it can be ill-defined and mild mass effect can be there. And on axial sections in multiple sclerosis, the lesion will be small, peripheral, ovoid, or wedge-shaped lesion. And it can extend to the central gray matter. And the contrast, it will be nodular or ring-like enhancement can be seen in MS. So here we can see in the cervical region, one small lesion is there, which is short. It is only one vertebral level, one vertebral segment. And here one more small lesion can be there. One more small lesion can be seen. So in this, one is enhancing, one is not. So dissemination in time is there. And here we can see the cross section of this lesion. It is showing almost like a homogeneous nodular enhancement, and it is towards the periphery, some mildly extending to the central gray matter, and a ring-like enhancement is seen. And this is the other lesion with the axial cut. It is a small peripheral wedge-shaped lesion with no enhancement. Coming to, so in for dissemination in space, according to the 2024 updated McDonald's criteria, optic nerve is also included. So there are total 5 anatomical location: optic nerve, intracortical or juxtacortical, periventricular, infratentorial, spinal cord. And 2 out of this 5 should be met for dissemination in space. And so to diagnose progressive MS, spine, if there are 2 lesions in the spine, that can be taken as dissemination in space. So we'll see the updated criteria. So the patient coming with the MS typical attack, or the patient with an objective progression, the lesion can be if there are no lesions, we cannot diagnose according to McDonald. If there is one, the patient can have a lesion at one anatomical location or 2 or more anatomical location. So if there is lesion at 2 or more anatomical location, dissemination in space is there. And if for progressive MS, if there are 2 spinal lesion, dissemination in space is there. So to diagnose it as MS, in dissemination time, if it is there, then we can take, or CSF positivity or the central vein sign positivity, if it is there, or if there is lesion at 4 or more anatomical location also, we can diagnose it as MS. And if there is lesion is at only one anatomical site, we can still diagnose it as MS if there is CSF positivity and central vein sign positivity. CSF positivity with paramagnetic rim lesion or dissemination in type and CVS, dissemination time and PRL. And for radiologically isolated syndrome, that is patient is coming with any other symptom like headache or seizures, or we have taken an MRI for any other symptom, and the MRI showing MS typical lesion, then that is radiologically isolated syndrome. So to diagnose that, lesion should be present at least in 2 anatomical location. Along with that, CSF positivity or central vein sign positivity or dissemination in time should be there to diagnose it as radiologically isolated syndrome. And so MRI also has a prognostic relevance. If a large number of lesions, more than 20 lesions, volume of T2 weighted lesion is more, the presence of infratendorial and spinal cord lesions, cortical lesions, multiple 2 or more gadolinium based enhancing lesions, a reduced whole brain volume, or with ventricular expansion, regional brain atrophy it is present, that means long-term disability. And lesion features are, if it is hypointense on T1, if the presence of paramagnetic rim lesion and a high proportion of lesions with central vein sign, if it is there, it portends a poor prognosis. So coming to the next primary demyelinating disorder, that is NMOSD. So MRI has an essential role in enabling the NMOSD diagnosis at disease onset and to confirm whether it is an attack or a pseudo attack. And particularly to diagnose in aquaporin for IgG negative patients, MRI is very important. So we'll see the MRI patterns. So at the disease onset, 80% of the NMOSD patients will have brain MRI changes, out of which 50% will have typical lesions suggestive of NMOSD. So these are the typical NMOSD lesion, that is optic nerve lesion, brainstem periependymal lesion along the lateral ventricles, diencephalic lesions, large corticospinal tract lesions, and hemispheric lesions. So we'll see each one of them. So optic nerve lesion, the lesion, around 15% of the NMOSD patients have bilateral optic neuritis at presentation, and the rest of them may occur later in the disease course. And the lesions in the optic nerve are typically posterior. It is longitudinally extensive, meaning more than 50% of the optic nerve will be involved, and commonly gadolinium enhancing in the acute phase. So here we can see the chiasm involvement, and here we can see the post contrast showing enhancement in the towards the chiasm. And also here also we can see bilateral posterior involvement of the optic nerve, including the chiasm. So coming to the diencephalic lesions, so these lesions are found in the thalamus, hypothalamus, and anterior part of the midbrain, and they are usually frequently asymptomatic, or sometimes the patient can present with SIADH, narcolepsy, hypothermia, and other endocrine manifestation due to the hypothalamo-pituitary axis dysfunction. So here we can see bilateral thalamic periependymal thalamic lesions, hypothalamic lesions, and the anterior part of the midbrain, medially, the periependymal surface can be involved. Then the hallmark feature of NMOSD is the area prostrema syndrome, in which the patient presents with intractable nausea, vomiting, and hiccups. So here the lesion will be in the unilateral or bilateral dorsal medulla. And here in the sagittal section also we can see the typical site for the area prostrema syndrome. And then in the brainstem, it will involve mainly the periependymal surface, like the floor of the fourth ventricle in pons and the surface, subpile surface, and also the dorsal part of the midbrain, and also around the fourth ventricle, the periependymal surface in the brainstem is a typical site for NMOSD. And sometimes these lesions can extend to the cervical cord, mainly in the periependymal central part of the cervical cord, as an LETM. This kind of lesion is also like typical for NMOSD. And in post-contrast, we can see patchy enhancement. The whole of the lesion usually won't enhance. Some part of the lesion will have a patchy type of enhancement in NMOSD. Coming to corpus callosal lesions, so compared to the lesion in MS it was small ovoid lesion less than 3 millimeter. So here we can see large multifocal edematous heterogeneous corpus callosal lesions, and mainly the splenium will be involved in NMOSD with edema. And sometimes it can be broad-based lesion will be following the course of the ependymal lining in adjacent to the lateral ventricle like this in NMOSD, and nearly extending more than 50% of the corpus callosum might be involved in NMOSD. And usually this posterior part involvement is more typical for NMOSD, and corpus callosal lesions are found in 12 to 40% of the patients with NMOSD. And this corpus callosal lesion is said to have a marbled pattern, that is the design of a marble, and or this splenial involvement extending to the bilateral periependymal subcortical region that can have an arch bridge type of pattern, described pattern in NMO. And then sometimes large confluent unilateral or bilateral subcortical deep white matter lesions can be seen in NMOSD. Like this extending from the periependymal towards the subcortex with the patchy type of an enhancement. And this sometimes this lesion can undergo atrophy, and cavitatory changes can also come chronically. And this is also another lesion which is in the involving the splenium and extending towards the periependymal subcortical region with this along the periependymal lining can be seen in NMOSD. And then the other typical lesion is a corticospinal tract lesion, which is also like longitudinally, it will extend from the internal capsule towards the cerebral peduncle. It can be unilateral or bilateral, like this in the coronal cut. Coming to spinal cord lesion, the typical lesion is LETM, longitudinally extensive, that is, it should involve 3 or more vertebral segment. So that is reported in 70% of the NMOSD patient. However, 25% of the patient can have short segment transverse myelitis also. And cervical spine is the most common location in NMOSD. And the spinal cord lesion can sometimes have cord swelling, can be like looking like an expansive swelling can be there. And here in NMOSD, around 70% of the patients can have T1 hypointensity. Compared to MOGAD, this T1 hypointensity is very rare in MOGAD patients. MOG can also present with LETM. So here 70% of the patients can have T1 hypointensity, and around 90% of the patients, there will be gadolinium enhancement in MRI. And in around 75% of the patients, more than half of the cord area in the axial section will be involved. And mainly it will be a central lesion involving the central gray matter. And in T2 weighted sequence, we can look for this bright spotty lesion, which is specific for NMOSD. That is, a high signal will be seen. So in the sagittal section, we can see extending from the inferior to the medulla, there is a LETM, which is involving many segments, and with some part of the lesion will be enhancing. It can have a lenticular type of an enhancement, ring-like an enhancement can be seen in NMOSD. And here we can see in the T2 weighted lesion, this bright spotty lesion. That is, some part of the lesion will have a T2 hyperintensity. That is the bright spotty lesion. And here we can see more than almost like 75% of the cord is involved, and predominantly the central part will be there involved. Here also we can see longitudinally extensive transverse myelitis with the central part of the cord being involved with bright spotty lesion. The non-specific lesions, these are very common in NMOSD. In non-specific deep white matter lesions and subcortical lesions can be seen, but this is usually asymptomatic and it is not specific. However, it can be seen in 35 to 84% of the NMOSD patients. And the enhancement pattern In the brain, around 9 to 36% of the patients have enhancement. However, in cord, around 90% of them have the gadolinium enhancement. And in the brain, the enhancement pattern is known as a cloud-like enhancement, that is poorly marginated, subtle, multiple patchy enhancement. And then along the ventricles, we can have the pencil thin type of enhancement. And sometimes well-marginated nodular enhancement and meningeal enhancement has also been reported in NMOSD. So here we can see multiple small patchy, uh, poorly demarcated enhancement, which is termed as a cloud-like enhancement pattern in NMOSD. And here we can see along the ventricles, it is enhancing like a pencil thin enhancement. So we diagnosed NMOSD using the IPND criteria. So we have 6 core clinical characteristics, as we know: optic neuritis, acute myelitis, area prostrema syndrome, acute brainstem syndrome, and diencephalic syndrome, and cerebral syndrome. So we can see that in 5th and the 6th, that is diencephalic as well as a cerebral syndrome, to diagnose, we need the MRI. So if at least one core clinical plus aquaporin positive, then we can diagnose. If aquaporin is negative, then 2 core clinical characteristics should be there. And along with that, that is a dissemination space. 2 core clinical core lesions should be there. And out of that, one should be optic neuritis, transverse myelitis, or area prostrema syndrome. And to diagnose this lesion should also the means MRI requirement should also be established. And we should rule out all the alternative diagnosis. So for optic neuritis, MRI requirement is normal cerebral MRI in the brain, and it should be a longitudinally extensive optic nerve lesion, uh, and involvement of the optic chiasm with enhancement. And for myelitis, it should be LETM. And if the patient has a history of myelitis, then the MRI should show the focal atrophy, which is longitudinally extensive. And area prostrema syndrome should have the dorsal medulla lesion. And other brainstem syndrome should suffice the MRI that we have previously described. And the diencephalic syndrome should have a periependymal hypothalamic or thalamic involvement. And the cerebral syndrome should be an extensive periependymal lesion or a corpus callosal lesion, extensive corpus callosal lesion, or a long corticospinal tract lesion, or large subcortical or deep white matter lesion. So coming to the next one, that is MOGAD. So optic nerve lesion in MOGAD is usually bilateral, and that is around 58% of the patient. It will be bilateral, compared to less than 5% in multiple sclerosis, and around 13 to 37% in NMOSD. And the lesions will have an anterior involvement. It will be longitudinally extensive, more than 50% of the involvement of the nerve, and optic nerve sheath involvement will be there in MOGAD. So here we can see a longitudinally extensive optic nerve lesion. Predominantly the anterior segment is involved. It is bilateral. And here also the perineural sheath enhancement will be there. Here the optic nerve is enhancing, the perineural sheath enhancement is seen. Here also it is seen bilateral. And here bilateral involvement of the optic nerve. This sequence we can see most of the patients due to the anterior involvement can have optic disc edema. So here in the MRI also we can see that optic disc edema. So coming to the spinal cord lesion, so most patients with transverse myelitis associated with MOGAD have T2 hyperintense lesion on the spinal MRI. Although 10% at the onset the MRI may be normal, and they often exhibit multiple spinal lesions either as LETM or STM, and 80% cases it is LETM. And the most acute T2 hyperintense lesion in the spinal cord, they are centrally located on axial image. That is around 75% of the patient have central cord involvement. And sometimes in 50% of them, it can be restricted to the gray matter alone. So that is the H sign we will see. And then the cornus involvement is more specific for MOGAD. And in contrast enhancement, it is less common as compared to NMOSD. In NMOSD, 90% of them had enhancement, but here it is less common. And if it is there, it is often faint enhancement can be seen. And often the spinal cord have the leptomeningeal pattern of enhancement in MOGAD. And most T2 lesions in the spinal cord resolve or reduce in size on follow-up, and spinal cord atrophy, but in severe cases, spinal cord atrophy can be there. And this accumulation of silent spinal cord lesion, which is typical for MS, is less seen with MOGAD and NMOSD. So here we can see an LETM, and here in the axial section, predominant gray matter involvement. So the H sign is seen. And here we can see in the post-contrast, the lesion is not enhancing, but the leptomeningeal and pattern of enhancement can be seen in MOGAD. And here we can see conus involvement, which is more typical for MOGAD. So coming to the brain involvement, so Adam presentation can be there, cerebral cortical encephalitis, and the patient can come with brain symptoms or cerebellar symptoms, and sometimes clinically silent brain or brainstem lesions can also be seen in MOGAD. And so the lesions appear um, uh, fluffy, that is poorly demarcated. It can be seen in the white matter as well as the deep gray matter. It can be unilateral or bilateral. And however, T1 hypointensity is very less common. It is uncommon in MOGAD compared to NMO, which can have more T1 hypointensity, and MS also can have T1 hypointensity. And the thalamic and the basal ganglia involvement is more specific for MOGAD. So the both white matter and deep gray matter involvement will be there. And sometimes this tumefactive demyelination can be seen, and around 22% of the cases, tumefactive demyelination can be there. And if it is there, it can be life-threatening also, because subfalcine and tendoral herniation can be there. And so this is difficult to differentiate if it is an MS, NMOSD, or MOGAD. However, in NMOSD, more frequent diffusion restriction might be seen. And coming to brainstem lesion, 40% of the MOGAD patients have brainstem lesions. It involves pons medulla and predominant MCP involvement, middle cerebellar peduncle involvement. And here the lesions will be adjacent to the fourth ventricle, not lining the fourth ventricle. And uni or bilateral large fluffy type of poorly demarcated infratentorial lesions can be seen, especially in the middle cerebellar peduncle in MOGAD. And so here we can see asymmetric lesions. It is poorly demarcated fluffy type of lesions in the thalamus, as well as both the deep gray matter as well as in the subcortex white matter. And here just adjacent to the fourth ventricle, and it is inside the lesion, poorly demarcated fluffy lesions can be seen, asymmetric. Here involving the middle cerebellar peduncle, large fluffy lesion can be seen. And coming to the flames presentation, here cortical lesion along the gyri, in the T2 flare, we can see enhancement. So these kind of lesions with seizures is known as a flames kind of presentation. And the gadolinium enhancing lesions are commonly described as nodular or perivascular type of enhancement, and leptomeningeal enhancement can be there, along with cortical linear enhancement can be there. And basically, MOGAD on follow-up will show resolution of the T2 lesions. And complete or almost complete clinical and radiological resolution will occur in 70% of the ADAM patients in MOGAD. However, in children, sometimes these lesions can have a leukodystrophy-like pattern. Then the patient can have a poor outcome. So here we can see the gray matter involvement in the cortex with this leptomeningeal enhancement, which is seen in MOGAD. So to diagnose MOGAD, the one core clinical demyelinating event with the positive mock test, that is cell-based assay, clear positive, then we can diagnose it as MOGAD. And the core clinical are 6 core clinical characteristics are there: optic neuritis, myelitis, ADAM, cerebral monofocal or polyfocal deficit, brainstem or cerebellar deficit, and cerebral cortical encephalitis. And so if the antibody is antibody is negative, then we should do the aquaporin antibody, and that should be negative. Along with that, one supporting and clinical or MRI feature, if it is there, then we can diagnose it as MOGAD. So supporting clinical MRI feature is for optic neuritis, bilateral involvement, longitudinally extensive involvement, perineural optic sheath enhancement, and optic disc edema. For myelitis, LETM with central cord lesion or H-sign cornus lesion, and brainstem or cerebral syndrome, multiple ill-defined supratentorial and infratentorial lesions, deep gray matter involvement, and ill-defined T2 hyperintensity in the pons, MCP or medulla. And if it is a cortical lesion with or without overlying meningeal enhancement, if it is there, then we can diagnose. So now we'll see the MRI on follow-up. That is remission. So the pattern of remission is relevant for differentiating between NMOSD, MOGAD, and MS. So after an acute event, so in MOGAD, this remission will occur. 60 to 79% of the patient will have remission at approximately 3 months from appearance, and smaller lesion can show faster resolution. And if we give steroids also, the lesions will resolve faster. And but this remission is only occasional in NMOSD, because only 14 to 27% of the patients, these lesions will remit. However, large reduction of the lesion can be there, and progressive fragmentation of the lesion will be there. And in MS, it is this resolution of the lesion is very rare. Only in 0 to 17% it will resolve. So, and in MS, new asymptomatic lesions or enlarging to T2 lesions are well recognized to occur. However, in aquaporin, NMOSD, and MOGAD, the frequency of new or enlarging asymptomatic T2 lesions is rare. That is 3 to 13% in NMOSD and 3 to 14% in MOGAD. So here we can see the pattern of resolution. So first one is a MOGAD in which bilateral optic neuritis anterior involvement was there. So there is not much of atrophy which is set in. However, in this is NMOSD in which posterior involvement is there, which is associated with much more atrophy. And in optic nerve, in MS, it is a short segment lesion, and short segment atrophy can occur in MS. And this is the spinal lesions. So in MOGAD, it is mainly multiple lesion, and the cornus involvement will be there. And in gadolinium, the leptomeningeal type of enhancement or a short central enhancement can be seen in MOG. And on follow-up, the cord has not much atrophied, and the lesions have mostly resolved. So this is a pattern in MOGAD. In aquaporin NMOSD, it is a single lesion, an LETM type of a lesion with a central involvement, showing a lenticular pattern of enhancement. And on follow-up, this lesion has reduced in size, and the cord will show some atrophy. So here we can see it was an LETM, and on follow-up, it has become small. And in MS, there will be multiple short segment lesion on axial section showing wedge or ovoid type of peripheral lesions, and on follow-up, new lesions will come, and which may be asymptomatic also. Here we can see new lesions coming up on follow-up. And in brain, in multiple sclerosis, small periventricular lesions are there with open ring enhancement or a ring type enhancement, and on follow-up, more lesions are there. And in NMOSD, on follow-up, the lesions will reduce in size with some atrophy, and this non-specific white matter lesions can be more on follow-up. And this enhancement will disappear on follow-up. And in MOGAD, as we can see, the patient will have MCP involvement, deep gray matter as well as white matter involvement, a cortical type of an involvement with a leptomeningeal type of an enhancement. And on follow-up, most of the lesions will resolve on follow-up with not much of atrophy setting in. And MRI, there are indicators for poor prognosis. In multiple sclerosis, the lesion load, the number of lesions, if it is high, at least when two gadolinium enhancing lesions are there, then reduced volume, the deep gray matter volume, as well as lesions in the motor tract, in the corticospinal tract, as well as corpus callosum, as well as infratentorial lesions and spinal cord lesions, they harbor a poor prognosis. And on follow-up, if there is reduced cervical and thoracic cord area, that harbor a poor prognosis and more disability. In NMOSD, the persistence of gadolinium enhancement, the reduced hippocampal volume, the length of the lesions. If it is a more lengthy lesion, and on follow-up, if there is cavitation and atrophy, it harbor a bad prognosis. And in MOGAD, especially in pediatric patients, if there is a leukodystrophy-like pattern or extensive cortical lesion, it harbor a bad prognosis. And also infratendorial as well as reduced cervical cord area and lesions in the corners will have a poor prognosis in MOGAD. So to summarize, we'll see the differences. So in optic nerve involvement, in NMOSD and MOGAD, there will be bilateral involvement and LETM type of pattern. In aquaporin, it will be posterior. MOGAD, it will be anterior. MS also, will be anterior to middle, intraorbital and intracanalicular part. And optic nerve enhancement will be seen in all of this. And mainly in MOGAD, we have optic nerve sheath enhancement and perioptic fat enhancement, as well as disc edema will be there in MOGAD. And for spinal cord, this NMOSD and MOGAD will have LETM. And in MS, it will be short segment lesions. And more of central lesion can be there in aquaporin as well as MOGAD. But in MOGAD, that etched kind of pattern will be there. NMOSD, this bright spotty lesions we can look for. And more of white matter involvement, short segment peripheral lesions will be seen in multiple sclerosis. And the location, in all of the cases, cervical is more common, but cornus involvement is seen in MOGAD. And type of enhancement, lens-shaped enhancement will be there in aquaporin. Faint enhancement or not much of enhancement will be seen in MOG. And a ring type or a nodular enhancement will be seen in multiple sclerosis. And a leptomeningeal pattern of enhancement is seen in MOGAD. And in the brain, in aquaporin, we can see that hemispheric or a long tract, corticospinal tract lesions can be seen. In MOGAD, it can be cortical and deep gray matter involvement can be seen. MS, mainly look for Dawson finger type of lesions. And corpus callosum lesion will be more in MS, but it can be seen in aquaporin as well as MOGAD. And deep gray matter involvement is seen in MOGAD. And MCP involvement is more seen in MOGAD. And T1 hypointensity is more, black holes will be seen in MS. And ring type of enhancement will be more suggestive of an MS. And looking at the resolution part, MOGAD lesions will have more resolution and asymptomatic lesions will accumulate in MS.
So I'll just share some of our experiences of central vein sign, which we use. It's very important design now for differentiating from the other two conditions, also from other white matter hyperintensities due to vascular cause, all these things. However, in a regular setup, SWA is not picking up these issues, probably because we are regularly doing point by test time. Probably we start doing pre-test better, and there are now newer methods by which you can co-register the SWA onto the flare sequence for picking up these lesions. So something like that we have to do. We tried with EPI, D2, many other techniques we tried, but still the central vein sign is not very well visual. So we have to do some work on that. And then the paramagnetic implications, we've done a lot of work at the paramagnetic implications. We are seeing it. And by a technique called quantitative susceptibility mapping, can even tell how much of deposition of iron is happening around these fields. So they represent chronic active lesions. And as you told, it is very important for prognostication, the presence of chronic active lesions. So these are the new two things. Also the cortical lesions, where double inversion recovery sequence we are not regularly doing, but it will become, even the flare sequence fix it up. But what I have seen is, in general, radiologists are still going back and not reporting these three things. So you should ask the radiologist, we want to know about the cortical lesions, the paramagnetic lesions, and this central vein side, so that they start reporting these. Similarly, the spinal cord lesions, you were telling about the T2, but the same criteria, and you know about Magnum's criteria, no? Where the Magnum's is the specialists of MR and neurologists and radiologists sat together and came out with this MR protocol. So in that, they are also telling that T2 still sequence. If you don't see it in the T2 sequence, still sequence will also be quite good. And sometimes post-contrast flare is very good to sequence, especially for looking at meningeal enhancement. You told some of these conditions are producing meningeal enhancement, especially flames. And also sometimes in other conditions also you get, even there are articles which says that even in MS, though you have told that it's not seen, even in MS it can occur. We have never seen it. For leptomeningeal enhancement, our usual technique that we use here is T1 contrast. But sometimes at least you will have to do flare contrast. We have already seen it in meningitis. So this is also something which we have to do. So yeah, so these are the things I wanted to discuss. We have covered the topic. Any doubts you have, let us anyone. I don't have any specific questions because she has covered the topic right.